So good afternoon. So really I'm excited to moderate this VOE on the radiation oncology alternative payment model. And I thank you for taking the time of your busy schedules as we try to discuss a lot of different facets of the model and how it's going to affect not only just brachytherapy, which I think it does have a lot of impacts, and we'll go through those today, but really the entire specialty as a whole. For those of you who don't know me, my name is Peter Orio. Many of you do know me being a previous chair of the ABS Social Economic Committee, ABS's past president, and now the past chairman of the ABS board. I'm a practicing radiation oncologist specializing in G malignancies at Dana-Farber and Brigham Women's Hospital in Massachusetts. My administrative duties include being vice chair of network operations for the organization. So we're kind of really paying attention to how these APMs can affect our practices. Brigham Women's is in the model. Dana-Farber is excluded from the model as it's an exempt cancer center, and half of our network facilities are in and half are out. So a lot of jockeying of positions and trying to figure out the best ways to proceed. In addition to that, I remain active on ABS's Social Economic Committee, and I also have the honor of being a vice chair of the Astro Health Policy Committee. So hopefully somewhat well-versed, and hopefully we'll be able to answer numerous questions as we go through the program today. But I always say surround yourself by the brightest people possible, and so that's what we're doing. So we have Dr. Cate Yashar also with us today. She'll be joining us tonight. She's a previous president of ABS, chair of Astro's Health Policy Committee, a professor of radiation oncology and applied sciences, and associate chief medical officer for the University of San Diego. Much better climate. Dr. Stephen Frank, past president of ABS. He's a professor of radiation oncology, executive director of the Particle Therapy Institute, leads a lot of therapies for head and neck cancer. And of course, we know him in his role of advancing prostate brachytherapy and bending the curve to make sure that more people get it. Dr. Nikhil Thaker, he's a previous chair of the ABS Social Economic Committee. He's on the Astro Health Policy team. He is now the Chief Medical Informatics Officer for the Division of Radiation Oncology for Arizona Oncology, and a former Chief Medical Officer of all value-based programs at Arizona Oncology. Just an absolute wealth of knowledge. Probably one of the best, youngest, brightest minds, a young guy. And have a lot I'm looking forward to what he has to say for us tonight. We're also honored to have Wendy Smith of Health Policy Solutions, an ABS consultant in the health policy arena, and also Ann Hubbard. A lot of you know her as a director of health policy for Astro. Ann has been working tirelessly with CMMI, trying to correct some of the significant wrongs of the RO APM model, which inadvertently can bring our specialty as a whole some harm, and also related brachytherapy in its current form. So we'll go through some of that tonight, and then Wendy will be available to answer questions as well. I do want this session to be as interactive as possible. Ask everyone to sort of stay on mute, but when you're not talking, but please come off mute to ask questions. This is always difficult on Zoom, as we know. We're kind of in the Zoom environment, but we do want to hear your comments, questions, frustrations, and even some excitements that this model may be bringing you. We're going to try to answer all questions, and if we don't know the answers, at least we're bringing these questions to the forefront, which is going to require thought and remedy, maybe God willing, some good solutions. If you're not comfortable, sort of talking on Zoom amongst a bunch of folks you may or may not know, you can always type out questions. We'll be watching the chats. We can then bring these questions to the group the best I can. But again, I do encourage those who have cameras to turn them on. I see a lot of people I know out there, but I don't see their faces. It'd be fun to see faces since we don't get to meet in person any longer. It's the best it gets. All right, with that, let's roll up our sleeves and get to it. So I'm going to start off by asking a few questions with some of our committee members. And so, Nick, let me start with you. Can you do me a favor and describe what the RO APM is for those who may not know?
Yes, absolutely. Peter, can you hear me okay?
I can hear you just fine.
All right, fantastic. For this part of it, I'm just going to share my screen here real briefly. Hopefully you guys should be able to see, just a couple of slides here, which hopefully will help to outline what the RO APM is and really how we've gotten here, in particular, and really what the next steps are. before we could talk about 2020 and now going to 2021, where alternative payments are going and what that means for radiation oncology, where did this all begin? This all began with something called the MACRA, or the Medicare Access Chip Reauthorization Act in 2015. It established the quality payment program, which hopefully a lot of folks here know about. There were two pathways. There was the MIPS pathway and then the Advanced Alternative Payment Model pathway. And that's the one we're going to focus on right now, the Advanced APM pathway. And, before this year, essentially, and certainly before 2021, really there were no currently available advanced APMs for radiation oncology. And RADONCs were only passively associated with the oncology care model, the OCM, which is very medical oncologist centric, and it's looking at the total cost of care. But there weren't any advanced APMs for RADONCs so far. So since 2014, CMS has been exploring potentially new ways of testing episode-based payment models, and in particular, focusing on radiation oncology services. In December of 2015, Congress passed something that required the Secretary of Health and Human Services to submit to Congress a report on the development of an episodic alternative payment model for our specialty in particular. And so that brings us to what is the RO APM and where are we today? So the goal of the RO APM is to test whether prospective episode-based payments for radiotherapy episodes will reduce Medicare program expenditures and preserve or perhaps enhance quality of care for beneficiaries. They wanted to establish site-neutral payment systems. This is, I think, really important for everyone to know on the call, that essentially the vast majority of models that CMS has been working on, and in the future I think we'll be working on, are in efforts to be able to have site-neutral payments that reduce differences of site of service differentials. And the idea here is that they wanted high-quality treatment in perhaps fewer encounters, improved quality of life during radiation, and shorter episodes. Another important thing, though, is that this radiation oncology model would serve as an advanced alternative payment model, and there would be a chance for a 5% incentive payment. Many questions that we've been getting are, who exactly is a participant in this model? Well, it could be physician group practices, freestanding practices, or hospital outpatient departments. These are defined by tax ID numbers or CMS certification numbers. And this model is really only for Medicare beneficiaries that are eligible for Medicare Part A and enrolled in Part B. They cannot have Medicare Advantage as a primary payer. Hospice, PACE, United Mine Workers, those are all exclusions. The only way a patient would be able to opt out of the program is to move their treatment to another geographic location that's outside of the model, which we'll talk about hopefully later this hour. 16 different disease sites are in the model. So I've listed them out here. And really the only notable difference between these 16 sites now versus in the proposed model a year ago is that CMS has removed kidney cancer. And there's several reasons for that, but in particular, I think good reasons to have kidney removed from the model. But you can see these are the 16 remaining sites here. They're identified based on ICD-10 codes. And if anyone's got interest in, sort of talking offline, I've done a lot of algorithm development on, trying to reproduce this model in the background, and happy to walk through some of the specifics. But in particular, the 16 different disease sites are described by ICD-10 codes. And the RO model is going to include everything from treatment planning through simulation, dosimetry, technical prep, treatment delivery, and then all radiation care up to 90 days post-treatment planning. It's going to include a very wide range of models and modalities, so all the way from 3D to IMRT, SRS, SBRT, protons, IORT, IGRT, and brachytherapy. There's a question right now about IORT and specifically being pulled out of the model, and perhaps something that will be discussed in the future. And there are certainly ongoing discussions with CMS about that. And of course, for our group, brachytherapy in particular is in the model. There's a very long list of these codes, and I'd encourage you, if you're interested, to look at these codes that have also been described by CMS. There are some exclusions, including the E&M services, so follow-ups and consultation codes, proton therapy if within federally funded multi-institutional randomized trials, and also neutrons, hyperthermia, radiopharmaceuticals. Certain types of complex brachytherapy surgery, which we'll talk about perhaps a little bit later this hour as well, and we'll go through. And then certain brachytherapy, brachy sources and elements that are not done in a hospital outpatient or freestanding setting, but in the ambulatory surgery center site of service. This part is really important, and we're going to come back to this, I think, hopefully over this hour. But the episode of how it's triggered, the length of the episode, all of that is extremely important. This is really the nuts and bolts of the way that episodes are basically paid for in this model. The treatment planning code, whether it's 77261 all the way to 263, and it's most common 263, us sort of dropping that code initiates the episode of care. And then at least one radiation therapy service must be delivered within 28 days of that treatment planning code for that episode to be triggered. If a radiation delivery is not done within 28 days, then there will be no episode that's triggered. That becomes what we call an incomplete episode. And then that goes to something called reconciliation in the following year, which we'll discuss as well. All expenditures up to 90 days after radiation treatment planning that are radiation-specific expenditures, those expenditures I just showed you, are reimbursed in the model. You can finish the episode out as early as 28 days after the treatment planning code, but if you still have some radiation services that happen up to 90 days, those are all bundled within that episode. And then between day 91 and day 118, you get paid fee for service. And then after that 28-day clean period, we call it, so that's 118 days after the initial treatment planning service, you could trigger a second bundle if that were to be medically necessary. And then last thing here, just on the brief introduction, is the timeline. And this has been a shifting landscape, and we've been working a lot in the background on this. Originally CMS had actually analyzed claims data from 2015 to 2017. Everything got moved up a bit. And now CMS analyzed your practice's claims data from 2016 to 2018 to be able to get a sense of the baseline. And initially they were going to start this model in January of 2021, but it will be pushed back to July 1st of 2021 up until December 31st of 2025. So you can see that timeline right there as well. And the last episode won't be able, it will start basically in October of 2025 to allow for some time for data collection. So Peter, hopefully in general, that's just a little bit of a sort of a lay of the land, the architecture of what these episodes are like in the RO model.
Yeah, that's wonderful. Can you go back to slide 14, the one previous? Let's do a few real life examples because I think it's going to be helpful because this gets a little complicated. Obviously everything we're going to do on an ICD-10 code is going to trigger this this bundle with the radiation treatment planning code. But the questions that come up and some of the questions I'm seeing now being privately chatted, in that 28-day model, so let's just do SRS, okay? So we're doing a brain met. If we decide to treat a brain met, but then 1 month later, the patient comes back with another brain met, do you have a run-out period, or is that all going to be encompassed with that same episode of care?
Right, absolutely. So, it will all come down to the specific timing between the initial treatment planning code and then when the second treatment planning code and radiation therapy services are going to be delivered. So in that case of 1 month, let's say they're doing SRS times one fraction. And then 28 days later, that patient is coming back and perhaps needing another SRS code. Since that's going to be within 90 days, that would all be technically within the same bundle of care. Even if that practice had dropped the end of episode modifier at the end of that first brain met treatment, still technically, if that second set of radiation therapy codes are dropped for that, even for a second site, within 90 days, that's all encompassed into that same bundle.
In the 28-day clean period, we can actually do another episode of care at that point. That is a fee for service before we trigger another bundle, or can you explain that a little more?
Yeah, that's right. So between 91 days and 118 days, that would be paid as fee for service. So just exactly as per the fee schedule that all of the practices currently get paid at. We wouldn't be able to trigger a second bundle until after day 118 from that first treatment planning code.
Okay. All right, so now let's get a little tricky. So how are we going to do, say, a prostate brachytherapy boost with this model if we're going to get beam and then brachy?
Yeah, absolutely. I look forward to everyone's thoughts on this. That's where it is really going to get, I think, very detailed here. There are some exclusions that I think are going to be really important for us to look at. Just as a public service announcement, CMS does have a webinar coming up on December 4th that is a billing guide. Unfortunately, CMS, they've said so far that they would be giving us further information regarding these specifics about billing, but they haven't been forthcoming about those yet. We're hoping certainly the December 4th webinar, and then afterwards, when they release a billing guide, we'll have much more specific information. But there is some information that we can tell right now. In the situation of where you have external beam radiation therapy and a brachy boost, as Peter, you were just mentioning, that could certainly happen in cervical cancer and certainly prostate cancer. In prostate cancer, it can happen where you get the boost first and then external beam afterwards, or you could get external beam first followed by boost. In cervical cancer treatment, it's external beam first and then brachy boost afterwards. It's going to depend a lot on who are the participants in the model. In general, if there is a selected participant, and that participant is the one who is, let's say, first starting with external beam radiation therapy. That person is going to be dropping the start of episode code for both the professional component and the technical component. And so therefore, that initial participant is actually the RO model participant. So let's say that RO model participant does 5 weeks of external beam radiation therapy, and then perhaps does need to refer that patient out to a second participant to do the brachytherapy afterwards. Well, it's going to depend a lot on that second participant. If that second participant is somebody who's also in the radiation oncology model, or is not in the radiation oncology model, but is not specifically excluded from the model. So is not in a PPS exempt cancer center, is not in Maryland, is not in Vermont, or is not specifically excluded by the model, then that brachytherapy will get paid fee for service to the second participant. But at reconciliation, which will happen a year down the line, that fee for service that's paid to the second participant who's doing brachytherapy, that amount of fee for service will be taken out of the primary participant, the one who actually triggered that bundle. It will come out of out of their dollars in what we call a reconciliation period. So that's sort of a very important point, because it depends a lot on who are the participants. Are one or more of the participants, are they excluded? And then what is the order of services? There's another situation where if brachytherapy is done first and is done perhaps by somebody who is not in the model, so perhaps a provider that is not in one of the CBSAs, not one of the zip codes selected, there would be no triggering of the bundle at that point. And then if, let's say, after that brachytherapy is done up front, perhaps as a boost, and then the external beam is to be delivered by perhaps somebody who is in the model, then that model doesn't get triggered until that patient has started external beam. So therefore, it really is going to depend a lot technically on who's involved.
Thank you. So I know that that's really complicated. I'm going to ask this question again. So Wendy and Ann, stand by, because I'm going to get to this one more time from a different perspective, because this is hugely important, because obviously it does have a lot of impact to brachytherapy. But let's just change gears for a moment. Cate, let me ask you. I mean, you're very much involved with health policy with both ABS and Astro. This can't be all bad. So what did this model get right? And of course, what are some of the deficiencies that you see as well?
Well, as you thanked the people that were on the phone, Ann Hubbard, Wendy Smith, Brian Hall, Victoria Hudson, they've worked tirelessly with CMMI and CMS to develop this model, trying to help them get it right so we could have stability of payment, because that's what we wanted. And then I get right to, oh, CMMI, how do I hate thee? Let me count the ways. I mean, there's more wrong than right, I guess I would say. And we're going to talk a little bit about this. I'll kind of list some of them at a high level, and then I know we'll get a little bit deeper. The discount factor, we wanted those to remain at 3% for the PC and the TC, and they're 3.75 and 4.75. And I'll talk a little bit more about that. In addition, because of the change in the conversion factor, fee for service, they'll get a 6% cut if you're outside the model, but there'll be a 3% cut in the model because of the trend factor as you average those going forward. Also, as you know, we asked for the national base rate to be based on hospital and freestanding services, but CMS has still chosen to just do the HOPS, or the hospital-based services, which is a disappointment. We asked that they have a separate palliative care episode because obviously there's very short courses, but that again was not something that they saw fit to do, at least at this time. Cervical cancer we're going to go into in more depth. we can't seem to explain to them that it's not a duplicate service when they go for brachytherapy, that they're separate and distinct, and Nikhil has already kind of gone into some of the problems with that. And again, we've all, Astro's worked really hard around the APC methodology, and even though we've gotten a bump, it's still very low. But even after that, there was in the RO model about a 20% reduction in the PC charges and a 16% in the TC charges. So when we go back to what Nikhil said, if those in the model already have a discount and those outside of the model do not, when they go and take money back from those in the model, it really puts a disadvantage, and we worry about what that's going to do for already these vulnerable patients. The other thing is we want it to be determined as an APM, and everyone gets a 5% bonus, including both professional and technical. Even though we're really happy for the delay to July, it does put us in a bit of an awkward situation, because then only from July to December is that data collected, and if you don't reach a certain threshold, are some people that are in the model not going to be eligible for that 5% bonus? So that's a worry. The case mix methodology, it's different between freestanding centers and hospitals. That wasn't taken into account. And how do you take into account what happened with COVID? How do you take into account places that have really been hit hard by the COVID, and patients have delayed care, and now we have patients coming into the system, which has already been shown with more advanced cancer, and how does that affect kind of case mix, all of that. Efficient and non-efficient practices, we had complained that efficient practices were already getting, were already doing well, and why should they then have a decrease in payment? But that has continued. Also, for inefficient practices, they might see a big change in how much comes in, and as you know, we have a large capital outlay, even with our machines, so that's a difficult thing. I think Dr. Frank is going to talk about what you need for new equipment, new service lines, innovative technology, so I'll let him go over that. And then there's all the data collection issues. It takes money to collect all these new data. They're asking for more data than we think has really been shown to be impactful on patient care. If we're going to partner with vendors to develop systems to do that more easily, that also costs money, and I think that'll end up being passed on to the radiation oncologist as well, and the practices. So that's a problem. There's just so much. I guess I'll stop there, and then we can go into the more specific ones related around brachytherapy. But there's a lot, and people are working tirelessly to correct these.
Yeah, no, I think you're right. I mean, the intention was good. We're trying to figure out ways to be good stewards of what we do in care, and have be financially remunerated in a correct sort of way. But I think the pendulum swung way in the wrong direction. I think we're going to feel the after effects if we can't make some corrections, which obviously a lot of individuals are working hard upon. And you can just tell as we sort of speak the speak, you can realize how complicated this does get, because I'm listening to it almost as a different language, and I'm actually involved in it. So we just
actually, Peter, before I forget, can I say one more thing? Whether you're in the model or out of the model, we will all be affected. And so if you have not reached out to your senators and congressmen about your displeasure, then you should. As soon as this is over, please do that. You can just get a link right to it on the Astro website. Sorry, I just wanted to make sure we said that at some point in this.
Yeah, no, it's important. And it's also important to know if you're in the model or not. So if you haven't checked, please do. The urgency is a little less because this has got pushed to July 1st, 2021, not January 1st, 2021, but still you need to do some planning, and hopefully we'll have some corrections in place by then. So Stephen, Kate kind of did a segue to sort of, what we're going to do going forward. And I know at MD Anderson, you have a role with a lot of strategic planning and thinking of when to bring on new service lines, buy new equipment, and sort of have an understanding of what's going on of, where do we go into the future? And I know MD Anderson is one of the 11, except cancer hospitals. But what do you think the RO APM might do to those mandated for participation in terms of planning for new equipment, upgrades, new service lines? And bottom line, is there a potential patients will not be cared for appropriately? Will the balance sheet just not meet up if we're going to be taking in less and expending more?
Yeah, I think when we initially thought of RO APM, Peter, and I appreciate that question, I think we all thought that, especially for brachytherapy, and I'll stay focused on that for the purpose of this call. We all thought that we've sort of been a stepchild. We're undervalued to a large degree. We provide one of the highest values with the ability to cure in one outpatient procedure on the prostate side, or in combination in a shorter duration with a very high value. I mean, and in gynecologic, we've been able to demonstrate a survival advantage by using brachytherapy in addition, as opposed to just using IMRT or external beam alone. So I think from the ABS standpoint, we've really felt that we've articulated the value that we provide. However, the reimbursement has not always been associated with that value, even though we've tried to create models, in working, whether it's, through radar plots that Nikhil has been very involved in with myself and up at the Harvard Business School, to really help articulate and communicate the value. I think that the ROPM had an opportunity to really provide us with a moment where if everybody got paid the same amount, then naturally the stepchild becomes the golden child. And we sort of thought that we would be able to take that margin and that would drive more people to do brachytherapy. However, there are a few different items that have been embedded within this that have created disincentives. Nikhil brought up one. So if somebody doesn't have the brachytherapy expertise, but thinks that needs to be part of the patient's treatment, I would commonly have patients referred to me after they get external beam. But now there's a disincentive to do that, and that can impact the patient's ability to get that kind of care, because it can come around on the groups within the zip codes in our area, because we are in the zip code area, we're just exempt. From a technology standpoint, if we look at the seeds themselves, those have generally been pass-through costs, and those now are going to be incorporated into the financial accountability of the 90-day payment. And that has significant implications, specifically for different seed vendors. That one seed currently might cost more than another, and that has negative impact. And so that can affect patients getting access to certain level of care that the physicians deem appropriate for their patients. So that's a problem. With respect to innovation and adding new innovation, it has impact, because the investment into that innovation needs to see that there's going to be a pathway to getting paid for that innovation. And the pathway and the payment of that is not entirely clear. And that creates uncertainty, and that uncertainty causes pause with applying new innovations into the treatment. Those are a few of the concerns that are seen, and until we get a better grasp and understanding of how to articulate this, it seems that while brachytherapy might get a little bit more, it might also be a negative incentive. And so these are the things that we need to work with, the Anns, the Wendy's, the Nikhils, to really, and to yourself and to Cate, to articulate back to ensure that we're not compromising and changing the sequence and the use of therapies through this modeling.
Thank you, Stephen. That was a great, very thoughtful answer. I'm going to circle back to the isotope question in a few minutes, because I just want people to digest what we're saying, because I know there's a lot of stuff going on. So I've kind of sort of set up my questions for everybody in a way that we are going to talk, then we're going to take a step back, talk about something else, and go back to things. I'm getting a few comments on Zoom, but we will kind of get back to the meat and potatoes of what we know is affecting brachytherapy. So Ian and Wendy, since you're both on the line and so generous with your time, I want to ask a couple of questions. Let me start with Ian, and then Wendy, I have a kind of a follow-on question for you. And this is something that's been, sort of we keep hitting on it. We're going to hit on it multiple times today because it's so important. But Ian, a major concern of the RO APM is how physicians will be reimbursed when one provider does external beam radiation and another provider does brachytherapy, as discussed by Nick and Cate. And and Stephen. As it stands now, the episodes of care for combined modality therapy, beam and brachy, be it for prostate cancer, GYN cancer, will provide one payment for all services. We know this. And even though adding brachytherapy into external beam is hugely resource intense, takes a whole different village of dosimetrists and physicists to get it done, which is a lot of overhead costs, we're going to get basically the same. So it's a huge financial kind of toxicity, honestly, to go about doing this without just doing something on beam, which you have a fixed overhead cost for. All right. So therefore, if I do beam and brachy for my patients, and I'm already being paid at a discounted rate, as Cate was talking about, because of the discount factors for the technical and the professional, seems like, again, a huge disadvantage, right? Even though we know brachytherapy provides a huge survival benefit in cervical cancer, like 20%, and a biochemical survival benefit in high-risk prostate cancer. So, I mean, it's important.
Yeah.
So how will this play out if I do brachy and another physician does beam, and either order brachy first, beam first, doesn't matter? And how does it play out if both physicians are in the model, or one's in the model and one's not in the model? Because, as we're discussing, I called in this morning in a panic, asking questions and stuff, as I often do. And you hear this term clawback, and we heard reconciliation from Nick. How's that all? That doesn't sound good. So can you kind of walk us through a little bit of this?
Sure. So if you have a situation where you are providing the patient with external beam treatment, and you make the referral to brachytherapy, and you're, say, at a freestanding setting, and you are initiating that episode of care, you will get the episode-based payment for that combination external beam brachytherapy service. The physician who you've referred the patient to, who may be operating in a hospital outpatient setting, will get paid fee for service. Now, at reconciliation, that incorrect payment withhold will be utilized as a funding source to take those fee for service payments back from the payment that you earned as part of the episode initiator to basically reimburse CMS. So they're not paying twice for those brachytherapy services. And the agency has said in the final rule that it will not take back or claw back more than the total episode cost. But the problem with that is that there's no guardrail in there to ensure that those costs of the services delivered by the second physician aren't, close to equal, or, maybe 80, 85, 90% of what the cost of the services that you provided. So that's a real problem. And that's one of the reasons why we really pushed the agency to make sure that they were getting the payment methodology correct and the payment rates correct for each of the disease sites. The cervical cancer example is a big one that we really pushed in the proposed rule, and we demonstrated that in that RO model data, the RO model data use file that the agency provided with the proposed rule, there were about 3,000 cervical cancer cases. And of those 3,000 cases, only about 600 included patients that had the guideline concordant care, which involved EBRT and brachy. And when we looked at the data for those 600 cases, the payments, of course, were higher. And so in our proposed rule comments, we said to the agency, you have to recognize the more expensive cost associated with guideline concordant care associated with cervical cancer. And so we recommended either you pay the different physicians who are involved separately, or you establish a payment rate that more appropriately recognizes guideline concordant care. And so we were really disappointed in the final rule that they disregarded that. And basically they based the payment methodology for cervical cancer on those 3,000 cases, many of which did not include guideline concordant care. And so I think that's an issue throughout each of the disease sites, and the determination of the payments for each of those. To the point that Dr. Yashar made earlier, they did not incorporate Medicare physician fee schedule data points in those national base rates. Those national base rates also include palliative care, so they're paid at a lower rate based on the inclusion of those palliative care cases. So there are many aspects of the payment methodology that the agency used to determine those national base rates that we really argued against. And it's unfortunate the agency did not see fit to make any modifications to recognize appropriate payment.
Yeah, no, very scary. So Wendy, just you've taught me a lot about comprehensive APCs. Can you kind of talk a little bit about the comprehensive APC and cervical cancer, because I know we've all had meetings with CMS, and how does that fit, what kind of this, or how does it get amplified in the radiation oncology APM? Because I think, obviously as you're setting rate, right, and if the rate's set incorrectly, it's going to be set incorrectly as you go through.
Right. No, it's a good point. The comprehensive ambulatory payment classification basically pays based on a primary service. And so we have argued for years that the payment methodology in the hospital outpatient prospective payment system has undervalued services related to cervical cancer because it's undervaluing the brachytherapy services that are utilized as part of treatment for cervical cancer. And so we've had a number of meetings with CMS over the years that have involved members of ABS, and we have sat down with them to show them if they were to use component-based coding to basically calculate the cost of services delivered with cervical cancer, that the cost in the APC methodology would actually go up instead of being undervalued as it currently is. And because the agency is using hospital outpatient prospective payment system data that uses those comprehensive APCs, which are undervalued, it therefore undervalues the services under the RO model as well.
That makes sense. Kind of snowballs, doesn't it?
It has a compounding effect. And, as much as we've tried to educate the agency on appropriate valuation, they've, clearly decided not to recognize our concerns.
Wendy, anything to add, Wendy Smith?
No, I agree completely with Ann's response. Yeah, I mean, comprehensive APCs have been a problem for a number of years. We've provided extensive analysis to the agency and provided comments and met with them, and we've just fallen on deaf ears, similar to, I think, how a lot of us feel CMMI has responded to radiation oncology stakeholders, via our comments to the proposed rule, and then, minimal changes to the final rule.
Yeah, no, it's clear that CMS doesn't want to make any changes to the comprehensive APCs, just a radiation oncology. They feel they work well for other sites, and we're kind of stuck in the crossfire with something, obviously, where it doesn't reimburse well for. And I guess, there's been a lot of efforts, a lot of flights to Baltimore for a lot of folks on this call, but I guess with the one win, because you have to be the squeaky wheel, as we did move up one level, correct, as Cate mentioned before, from a 6, I think, to a 7. So it's not enough, clearly, but it was something. It's, I hate to say it's better than nothing when nothing is so little, but it was something. So Cate, question to you. What do you think is going to happen if brachytherapy for cervical cancer is included in a single payment for treatment of this curative malignancy? When brachy's added to the care plan, same question really for endometrial cancer when you need to do beam and vaginal cylinders. Do you foresee this going away in this model, and is this going to impact patients, or do we think we can find a solution to make sure patients get the care they need?
Well, the big worry is that, there's data that shows that if you don't do this very often, brachytherapy, patients have inferior outcomes. So if people start doing brachytherapy, even if they're not comfortable, patients are going to suffer. Or if they choose not to do brachytherapy at all, and, I think Akila Viswanathan's on the phone, she had one of the first papers, and then Sushil Beriwal showing that if you use other modalities like SBRT or IMRT, it's not as good as brachytherapy, and again, there's a decrease in survival. What we would hope is that they would just send the patient from the very beginning to one center that can do both. But again, it's not even just up to the physicians, right? These sometimes patients are socioeconomically or socially disadvantaged. And so for someone that lives hours away from San Diego to come to San Diego, that's just not possible. So the problem is it takes the patient out of the center. It doesn't make the patient first. This is making, I don't know who it's making first, but it's certainly not patient-centered care. And that is a really very scary thing.
I agree. And, when you think about some of the disadvantaged populations where some of these malignancies sort of affect more than others, and now you're putting even more hurdles and barriers to care, it seems, quite disingenuous that we think this model has really any, sort of, patient forward or patient thinking approach. Obviously it can be very detrimental. And honestly, as it stands now, for all the reasons everyone has just mentioned, we are going to probably see an increase in death rates and overall survival in a malignancy, which oftentimes can be, curable. It's obviously a lot of work, and of course we're going to keep, at it. Stephen, I want to come back to you again, just on the isotope question. I do know we have a few industry members on the phone, and again, you can interrupt anytime, ask questions. I'm just trying to keep things moving forward, but I am kind of concerned, and Wendy and Ann, I'm going to ask some similar questions with the isotopes as well, because I really do believe this is going to be detrimental. Now, the LDR isotopes basically used to be a pass-through to patients, as Stephen was talking about before, but now it's by the RO APM technical component. So you're basically paying for the seeds you implant. And the reason why this is problematic is I can use super high activity seeds, which could be dangerous to patients if misplaced, or if I want to use a seed with a shorter half-life, they're typically more expensive. We know that iodine, we know cesium is more expensive than palladium. Palladium is more expensive than cesium, and basically, we know half-lives are from 60 to 17 to 9 days. Obviously, there's some issues when you're manufacturing things which burn out at a quicker rate. So this is problematic because I think it's going to limit physician choice. It's going to limit patient access. But Stephen, you've done the comparative analysis study with several isotopes. One of the kind of a randomized trial, which has been in the literature. But what do you think this is going to do to the practicing brachytherapist? Will this change practice as we stand now? If someone is using, say, cesium, but that's the most expensive isotope, do you foresee patterns of care being changed based upon reimbursement and what it's going to cut into sort of your technical component of reimbursement?
Well, I mean, I think that, Peter, we have to be honest about it, and we have to recognize that if you're only getting paid a certain amount, and there's no margin to your reimbursement and to your expenses, then something has to give. And if you're going to continue to offer the brachytherapy services, what may give is the type of isotope, the type of activity. It might start to change your practice, and I think that does have a lot of implications because it has different side effect profiles and it has potentially some different long-term outcomes. So I do think that these are issues that would have to be addressed and communicated to the CMS level, and with true case use examples and clear examples. And I understand what the CMS is trying to accomplish, with the RO APM. What I'd love to, we've looked at the responses that CMI have come back with, and uniformly the response is, we've heard you, but we're going to move forward with it anyway, and then we will identify what the unintended consequences are later. That seems to be the response from the from CMS in their communication, which I think is unfortunate. And I'd love to hear, if there's an opportunity to readdress that, or are we just going to be faced with looking at the model and having to understand it in hindsight, and maybe try to collect the data on that from the ABS standpoint to better understand what the implications are so that we can give that information back as quickly as possible in real time.
That's cool. Well, speaking of that, so Wendy Smith, Wendy, I thought there was a statutory rule in place that these seeds had to be passed through to patients. How do they find themselves in this model? Do you have any insights on that?
Yeah, well, basically, what they did was they did not, in the proposed rule, they had waivers of certain mandated legislation to address several issues. However, in the proposed rule, they did not include our piece of legislation as a waiver. Via the public comments, it was made clear to the agency that they failed to waive that particular piece of legislation. So they, in fact, did that in the final rule, giving them the ability then to bundle the reimbursement for the brachytherapy sources. So they were able to, like I said, they were able to do a legislative waiver, meaning that they can get around the Balanced Budget Act. So that's how they are getting away with it.
And so, Ian, obviously you're hearing a lot of concerns sort of on the isotopes, just because it does affect different things. And I think of just even myself in my training, I trained in Seattle. So, the guys at the Salem Prostate Institute would use, sort of iodine, palladium, low activity. I'd go over to the VA and, because of cost containment, would use the highest activity isotope that we can convince a manufacturer to make for us, which is all well and good if you know what you're doing. But if you don't, that one isotope can become, highly problematic and can create a lot of toxicity. So there are some concerns in my eyes, and just even in that arena, doing things which you don't intend to do, but you have to, as Stephen mentioned, create enough of a margin so you can employ your physicist and everybody else who it takes to do a good implant. From what you're hearing from us, what do you think the avenues are with Astro, ABS, as we go to CMMI, knowing there are so many concerns, especially around this issue right here, which used to have a precedent where we just pass it through to the patient and they could make their choice of what isotope they would wish to use.
No, it's
Right. Go ahead, Ann.
sorry, I was just going to say, one of the things that we've really tried to focus on at this point is just how flawed the payment methodology is and how burdensome the reporting requirements are. I don't know if you all have been able to look at the letter that we sent to the agency on November the 3rd. It's only a 10-page letter, so maybe they'll read this one. But it basically is a higher level overview of all of the concerns we shared in the proposed rule comment letter. We don't include language about the source issue, but I think if we can push them on the fact that the payment methodology is so incredibly flawed, that gives us an opportunity to readdress the source issue as well. And I feel like at this point, because they were so unwilling to accept some of our more detailed concerns in that proposed rule comment letter, we kind of have to keep it high level at this point, see if we can't get a foot in the door to make some changes, because technically this was a final rule. And as a final rule, it's not likely that the agency is going to make changes. And so to the point that Dr. Yashar made earlier, that's one of the reasons why we're really encouraging people to reach out to members of Congress and to share their concerns about the RO model, because a legislative fix may be the only way that we are able to make some headway here and get the agency's attention to make some modifications to more of these, very important issues around the payment methodology, around the inappropriate inclusion of sources, and that sort of thing. So that's kind of the strategy we have at this point moving forward with the agency.
Makes sense. And actually, Bill Bryce brings up a good point too. QA could be affected because according to the APM, the physicists and the ABS guidelines, we do assay a certain amount of seeds that we take from the vendors, and typically we assay them, we don't use them. I mean, I guess we could sterilize them, put them back in, but a lot of times they come in waves, which makes it more difficult. So we may be losing our second check in this model as well. So as individuals are thinking about penning letters to their Congress peoples, some of the things being brought up today, you may want to remember and include in that discourse with them.
And just to really quickly follow up on Dr. Frank's recommendation about sharing examples and really kind of helping the agency understand the issue around including brachytherapy sources and how that impacts practice decision making, that would be helpful to have too. So if you all can kind of share that information with me, we can certainly add it to our kind of next opportunity to push the agency on changes.
Yeah. I didn't do a poll at the beginning of the Zoom, but I'm assuming a lot of folks who are kind of zooming in with us today probably are in the RO APM and they have sort of concerns. But just because you're not in the RO APM doesn't mean it's not going to affect you or touch you in some way, shape, or form. If this is successful, then it may be rolled out to a wider population of patient practices. But of course, it's always a matter of time where the privates sort of follow the lead of the government as well. So I think we have to pay a lot of attention, and we need to do due diligence now, because once something gets traction, takes a foothold, it's a whole lot harder to reel it back than it is to make corrections up front. So we do encourage. We have a lot of folks on this call today to do some of the advocacy, which we're asking. So it is going to take a team approach. I mean, we're doing as much as we can, but unless everybody has a voice and speaks up, it's easy to push a few aside. It's much more difficult to push a lot of people aside.
Here, can I just add just one brief thing there? So, both last year and this year, and on multiple calls with CMMI, certainly even in the last few months, we've brought up multiple examples of multiple scenarios of brachytherapy alone, brachytherapy in combo modality with external beam, one practitioner delivering both, portions of treatment, two different practitioners, one who's excluded, one who's not, one who's in the RO APM, one who's not. And honestly, each time it feels like we're having this discussion for the first time, with CMMI. And I think that, it would really be, truly, I think, impactful for, a wider range of advocacy here as well. So, coming from us, it's starting to make a dent. Some are starting to understand that, okay, these are not duplicate services. These are, separate services that are still part of the same episode. But, certainly coming from multiple members, throughout the geography, and, certainly being able to go to your House members and your Senate members and others to be able to advocate on our behalf, I think will just put more pressure on CMMI that, as Ann said, this is a final rule. There's a little bit more of an emphasis right now on cost containment, and trying from CMMI's perspective to have a model that actually was successful in, cost containment. The only reason this model is currently slated to be cost contained is because of these very steep discount factors and perhaps, methodology that's somewhat flawed. And so certainly I think coming from multiple perspectives and bringing up these examples again and again will really help.
Well, that's good. Actually, one of my questions, Nick, was going to be to you too, is can you define the discount factor? When we're using language some may not understand. Can you just, how does the discount factor apply to the APM? We lost you. I think you might be on mute.
Sorry about that. Yeah, absolutely. So the discount factor is, essentially, this is probably one of the main areas that's going to impact RO model participants. Certainly, I think negatively, compared to outside of the model. Once CMS has applied a geographic adjustment to sort of where your practice is in the model, and they apply that to a trend in the national base rates to say, are your base rates going up or down for prostate or lung? So they apply all of these adjustments, including your case mix adjustments, your historical experience. And once they've done that and they've sort of applied these adjustments, then CMS applies something called a discount factor. The discount factor is basically a set percentage that CMS uses to reduce payment of both the professional and the technical component. It's a set percentage and it doesn't change based on the cancer type. It's a 3.75% discount on the PC and a 4.75% discount on the TC. And so when we sort of talk about, cost savings in the model and looking at the overall, savings that CMS is trying to go for, the vast majority of these savings are coming from these discount factors. And just to give you an example, the oncology care model it has a very different sort of set of discount factors in their two-sided risk model, where medical oncology practices, can share in the savings, or they have to pay something back if their costs are too high. Those discount factors are much closer to about 2.5 to 2.75%, whereas here we're in the 3.75 to 4.75%. So these are much higher than in some of the other models, and this has been a really main focus of advocacy for many of us.
And I was going to ask kind of a similar question. Why are the discount factors so high for radiation oncology, compared to some of the other models we've seen? Do we have a sense of why it feels a little punitive? And so what's going on there? Help us understand that.
So it does feel very punitive. The Medicare and CHIP Reauthorization Act included a requirement that advanced APMs have a nominal risk amount, and it's set at 3% of expenditures or up to 8% of revenues. And I think what the agency is doing is it's hanging its hat on that up to 8% of revenues. The thing that is very disappointing to me is that the agency is applying these high discount factors to radiation oncology, despite the fact that we have spent a tremendous amount of time educating them on the capital investments that are required to just open the doors and keep the doors open in a radiation oncology clinic. And so we really pushed the agency to lower that discount factor to 3% or less for the RO model in our proposed rule comments. But as Dr. Thaker mentioned, they only reduced the discounts by 0.25%. And this is an issue we'll continue to push with them, because practices really need to be able to invest in new technology, new service lines, and this model just doesn't allow for that.
That's exactly it. I mean, the profession can't stagnate if we don't have funds. It's highly technical, highly evolving, and obviously very expensive to buy what we need to use to treat patients. And this all can sort of stunt our innovation, as Stephen was talking about before, into the future. So, 2 minutes remain. I'm going to be cognizant of everyone's time, but are there any questions that we can answer? You have a team of individuals who are highly skilled, so I do encourage maybe 1 or 2 folks coming off mute and asking questions. And even if you typed out a question, it's hard for me to keep track of all the chat going on. So here's your opportunity to ask any burning question before we adjourn for tonight.
I will say that in all the scenarios we sent to them, I think the one that Sanford Katz put in the chat was the one that we missed, where he's a professional component working in a hospital, but he owns the technical component of the HDR and, of course, is the professional. Gosh, Nikhil, you gave him like 7 or 8 scenarios, and that's one that we didn't think of. So
well,
we might have to talk to him about that offline.
Interestingly, I actually did bring that up pretty recently, actually with
Good.
CMS. I was brainstorming additional scenarios, and I have a colleague who's in a similar situation as Sanford. So I did bring that up, and I didn't get a good answer. They did promise that they would provide more specific information in the billing guide, which would be coming out shortly. My assumption is that in a case like that, if you're billing the brachy globally, that portion of it, which would be separate from the initial technical participant, which would have been the hospital, you would end up having 2 technical participants. And so there would be reconciliation, most likely in August of the following year, for that portion that's billed, that TC portion, especially that's billed globally. So yeah, that's going to be a pretty messy scenario, but I think probably what would happen.
Yeah, we have the same scenario at our hospital where we do LDR brachytherapy, and I believe the professional component falls under the global episode, but the technical piece will be a challenge. And we haven't gotten a clear answer from anybody, because how are you going to split that technical on the external beam and the brachy? Who's going to decide what number is worth what?
Yeah, it's going to be CMS, I think, because, even though if you bill globally, each of these still has a PC and a TC component. So I think that they're going to use those individual PC, TC components, which initially the TC on the brachy in these situations, will get paid out as per, fee for service. And then that portion of it will, you'll get paid fee for service, but then in the following August, your hospital will get reconciled and subtracted, from those fee for service dollars.
Thanks for answering the question. You can see this is not going to help our relationship with our hospital. It puts us in direct conflict with our own institution.
I think both sides get reconciled in that scenario, by the way, because you're going to get paid on the TC on the brachy part at some global rate, and that they're both going to be reconciled.
Yes, they will be.
I'm sorry, could you repeat that? Because my assumption was that we'd have to stop billing globally for our brachytherapy, and just because our professional would be covered under the, globally with the external beam, and that we would then have to start billing just fee for service for the technical part. But you're saying we should continue to bill globally for the brachytherapy?
Yeah, so essentially under that scenario, you would continue to bill, globally in that situation as you normally do with fee for service. But what'll end up happening is that CMS will reconcile most likely the technical component of those dollars. The question that I have sent to them, which they've escalated up twice now in emails, and I haven't gotten anything back, is what'll happen on the PC side of it, because technically the PC, you are the participant who triggered the PC portion of it, and you are the same participant on the brachy portion of it. My assumption is that it's just the technical component that will get reconciled, because that's the only time that a second technical participant is introduced into the episode, while it's the same PC participant. So at least my read of it is that it's mostly just on the technical component, whether or not you bill globally or not, because it's very easy to split a 26 modifier for the PC and a TC modifier for the technical component, even if you're billing globally. But certainly, as I get information on that, I'll share that with you for sure.
I think there's also the complicating issue of if that zip code where you're doing the brachytherapy is in the model or out of the model. Is that correct, Anne?
So if you are basically shifting patient care from an RO participant who's in the model to, say, brachytherapy services that are delivered outside of the model or at an IPPS exempt cancer hospital, what the agency has said is that those services would be paid fee for service, But it sounds like, and this is something where I think the agency needs to clarify as well, the fee-for-service payments would not be reconciled against your incorrect payments because the second service has been delivered at a non-participating site.
And I think the one area of clarification is that in the FAQ that was recently released on 10/30/20, they did revise and update one of the questions, and in particular, it doesn't just matter if that second portion of care like brachy is delivered in a model in a practice outside of the model. It also depends on whether it's an excluded practice.
Right.
So that basically means that that's a practice that's specifically not allowed to be in the model, not just not chosen for the model, just not even allowed. So that includes PPS exempt cancer centers, practices in Maryland, Vermont, those hospital-based practices that are that qualify for the Pennsylvania Rural Health Program, and then there are just a couple other exclusions as well, like in territories.
The exclusion, sorry, just real quick, the exclusion also includes ambulatory surgical centers. So
That's
I'm
right.
kind of curious to see how that changes utilization of ASCs.
That's right.
All right, so I know we're kind of getting long on time. Let's just explore that one thought, 2 questions, because this is kind of interesting and it's going to happen if this goes through. All right, so Nick, maybe to you and then Ann, what would stop me from doing my HDR, LDR? Let's go to prostate cancer because that's, obviously a lot of money spent on prostate cancer. What's going to stop me from doing my HDR, LDR boost first and then waiting 3 months to get to a clean period to do my beam?
Yeah. So even to go one step further, for you to have a, let's say that initial episode, right? You have to have a treatment planning code and then, some treatment delivery code within the first 28 days, right? Mm-hmm. So in that scenario, if absolutely there's gamification that could happen here because you do, let's say, treatment planning, and then you continue with Lupron, let's say the patient happens to be on, and then right at day 28, you deliver your brachytherapy. So you've already made it to 28 days. You actually really only therefore have another 60 days left, another two months left. And then at that point, you could start billing fee for service. And then certainly after that, you could bill for, another episode. So there's the only thing that's going to be happening during that 5-year model is that there's going to be a monitoring that's happening, during this time frame. Several of us, know who the monitors are and the processes. I've been part of the monitoring for OCM, and so I've been part of the audit process. So I know that they look at those claims codes, and they will make adjustments if necessary.
I guess the other thing that came up, and then we're just going to end it on this because it is late, but we were talking about the 11 exempt cancer centers or ASCs. What would stop us from doing a beam and then sending the brachy to an exempt center or to an ASC? If we do that, are we still going to get fee for service if we do such?
Yeah, and something Ann and I have been talking about actually quite a bit in the background. We need clarification, honestly, on the billing side of it. I've asked many times with CMMI, and so has Ann. And the bottom line is, as of right now, we don't know the historical experience costs that have been calculated. Have they been calculated, without those historical dollars as part of the episode of that care delivered, in those PPS exempt cancer centers or Maryland or Vermont and other places. So we don't know that if the adjustments are taking that into account or not. But to answer your question, as of the way it's written right now, those excluded centers, if you send patients there, those dollars are not clawed back. They're not reconciled. So I certainly see that's a pretty strong possibility for those PPS exempt cancer centers.
Thank you. Not that we want to game the system, but I just want to make sure we're thinking of every avenue as, that's what we do.
Yeah.
And not to get in trouble. That was my own personal opinion, not Ann Hubbard's. So.
Right. And just to reiterate to Dr. Thaker's point, monitoring will take place. And the other thing you have to remember is that value-based payment is not going away, and there will likely be a rebasing period after the 5-year demonstration. And that rebasing is probably going to take place on what you did during the 5-year period. So, you don't want to put yourself in a situation where you're disadvantaged by, this opportunity that you've determined helps you during the payment model.
Right, exactly. You know, I think there's a strong chance that the no pay claims that the RO model participants will be submitting during these 5 years will become your new baseline in 2026. You know, if there's an expansion of the model, this is exactly what has happened in the OCM with the new OCF, and it's probably going to happen with the successor of the RO model as well. So it's important to know that what you do will impact you in the future as well.
Yeah, and a short-term state of execution for a long-term play. And I think that's something we need to remember as well. All right, so with that, I want to thank everyone for participating. Ann and Wendy and Stephen and Cate and Nikhil, thank you so much for your time tonight. Again, maybe tune in on, was it December 4th, the CMMI listening session? That might be helpful. New information may be provided to everybody. Obviously, there's still a lack of clarity, as you could tell from the discussion tonight, but you know, a lot of folks are thinking long and hard and petitioning CMMI for hopefully some good outcomes for the specialty. We've got a lot of challenges ahead, but together I know we will rise up to the occasion and get through them. Good night, everybody.
Good night.